Welcome to our online point of care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonal anatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
Thank you very much, ICOM team, Habiba, Nurhan, and Ala. And thank you very much for everyone who is joining this evening webinar. Hopefully you see my slides, Dr. Walid.
All good. Just put yourself on the full screen mode, please.
Sure.
Excellent.
So this is the point of care ultrasound in acute care settings, the advanced critical care module. The second module, which is, as we mentioned before, is endorsed and endorsed by European Society of Intensive Care Medicine, the EDEC, the European Diploma of Echocardiography, and umbrellaed by WICCEM, and in collaboration with Saving Lives Academy. This module has just started 4 weeks ago, and as we used to do, every 5th week will be for live webinar when the fellows meet the faculties, and it's purposely made for the fellows to ask their questions pertaining to the previous weeks. And we are very proud tonight to have this constellation of stars in critical care ultrasonography, Dr. Walid Al-Habashi, the director and founder of Saving Lives Academy and the academic director of the Advanced Critical Care module. We are very proud to have Professor Antoine Villar-Baron, who is one of the figures well known in the RV physiology, specifically echocardiography related, with tons of publications and textbooks in such science. RV dysfunction in critically ill patients, a big subject actually in ICU. We daily face such kind of cases. We are very proud to have also Professor Michel Slama, who is, as Antoine, also well-known faculty, well-known in the world for critical care echocardiography. Both of them are professor of intensive care medicine. Both of them are working in France. Let me just take you to the just a quick reminder of this meeting. It's also worth it to mention that this sort of live webinars, which we are conducting every 4 weeks, as we said, it's the chance for the fellows to meet their faculties after they've been studied the material on the platform. They can ask their questions and they can bring their cases. Though we don't see anyone until now brought the case for discussions. And this is one of the mandated actions of this fellowship, because as we mentioned several times before, we aimed to make this fellowship not only science, but also very practical. So we meet online, we meet, discuss your cases, because this is the one of the effective ways that you can gain the experience and we learn from each other. It's a win-win situation. Otherwise, if you don't bring your cases, we bring our cases to you and we discuss them with you. And we used to do pull like a quiz every live webinar just to review also the knowledge that we came across through the previous weeks. After this brief introduction, I'm going to give the mic and the stage for Dr. Walid Al-Habashi, who is going to moderate the poll questions and direct the answers. We're supposed to receive your questions in Q&A. So if you have any question related to the 4 weeks we had, please don't hesitate to write in the Q&A. The 4 weeks, as you know, where first week was advanced views by my friend Dr. Walid Al-Habashi. Advanced, the second week was advanced LV and RV assessment by myself. And the right heart syndrome was discussed with our professor, Dr. Antoine. And the infective endocarditis, the 4th week was with Dr. Michel Slama. It's very needed to be reminded also everyone that we are following your progress online. So every week almost, I'm going through the list of fellows in the platform and I see how they progress, how much percentage you are doing your assessment. Some of you are reaching 100%, means that they are doing every week, week by week. Unfortunately, some, they are 0% and remaining 0%. And those whom we are really encouraging them to actively participate and actively do the assignment. I know sometimes we all very busy, but please, the more you finish the material on time, the more you have time to think more and to practice more and to ask more questions and to share with us your cases. And the science that you learn online, please go and apply them, because as you notice, you might see, if you focus on the presentations, we insist for the faculty to be toward practical. So we give you the hints what to do bedside, and please take the chance to do that and bring your cases again and we can discuss with you. So there are many of you still not achieving the good achievement. They are still behind the 50%. And again, we're encouraging you guys to go through this material as soon as you can. I'm going to stop here, pause here, and then ask Dr. Walid Al-Habashi to start the poll now. And kindly, guys, you participate in the answering these questions through the poll. This is very important for us. We take it sometimes for statistics to see where we are we progressing or not? So, Dr. Al-Habashi.
Thanks so much, Dr. Ashraf, for the kind introduction. So our roadmap, you had attended 4 weeks. Every week, I presented around 3 questions, so total of 12 questions. So from each week, I picked the most important 2 or 3 messages and have chosen one question on each of these messages. So my task tonight is to cover your 4 weeks in 12 questions. Definitely, I'm not going to cover everything. I advise, as Ashraf said, that you share so you know if you had answered wrong, because we will discuss your answers immediately after the poll result or the quiz result is released. So you know where your weakness or where is the mistake. So don't sit passive, doing nothing. Please, we strongly recommend that you share your answers with us, how you think about the question. It wouldn't be very difficult, but it's meaningless if you did not really attend the lectures or you listened and watched the videos. But again, you may test your understanding and knowledge, because what we are covering in this 12 question had been already discussed. So the first question here, without further ado, is the thoracic aorta assessment. So the question is about thoracic aorta. Which of the following is not typically used to assess the thoracic aorta during point-of-care echocardiography examination of a shocked patient? The parasternal long axis view, the suprasternal view, the apical fold chamber, the parasternal short axis view at the aortic valve level, descending aorta view posterior to left atrium. And you may start putting your questions answer. Which is the following views is not? I don't see any timer there. So Habiba, please, if you allow like 30 seconds or so. I don't see the progress from the attendees. If we exceed 50% of attendees answer the poll, okay, perfect. So 62% answered the answer C, which is actually the right answer. So one of the very good things about point-of-care ultrasound is whenever you are suspecting a dissection of the aorta, you can trace the aorta from the parasternal long axis view, so from the origin of the LVOT aortic valve to the ascending aorta. This is the parasternal long axis. And if you remember from the same view, you can see just posterior to the left atrium, you can find the descending thoracic aorta. Then, if you go to the suprasternal view, suprasternal notch, you can see the arch of aorta. In the parasternal short, you have the perpendicular view on the aortic valve and the origin of the aorta, with all the cusps of the origin of the cusps and origin of the coronary arteries. Then, in the apical fold chamber, there is no LVOT, there is no aortic valve, there is no aorta. This is the right answer. But if you go from apical 4 to apical 2, you will find the longitudinal section of the descending thoracic aorta, and then one more view in the abdomen, which is to examine triple A. These are all the aortic views, so you can get the aorta from the ascending, the arch, descending thoracic, and abdominal aorta. It's even better than the transesophageal echo, one of the advantageous examinations in our real life. So second question is about the apical view maneuvers. So when we are moving from view to another, which maneuver is required here to obtain the apical 3 apical 3-chamber.
Can I
Once high quality,
Dr. Walid, Dr. Ahmed Abul Anin is asking, how can I join the poll? Can you please instruct him?
I believe that's Habiba, but you can, if you are attending this webinar from your phone, you can just slide the video to the right or to the left, because it depends on what, if you're iOS or an Android. It's a lot easier to attend the webinars from a computer because the polls will be like just in front of you automatically. But if you are attending from a phone, I think it is a scroll right or left, depends on your operating system. So back to our question number 2. If you are at the apical 2-chamber view and you would like to go to the apical 3, rotate the probe 90 degrees clockwise, 60 to 90, or counterclockwise 30 to 60. Tilt your probe anteriorly without rotation. Slide the probe one space high towards the axilla. Angle your probe medially towards the right shoulder. What would you do to bring the apical 3-chamber view when you are at apical 2-chamber view? That's an easy question. It's all about the 3D map in your mind. Again, we'll allow 50% or 30 seconds. That's an easy question. Excellent. So thank you very much. Looks that 73% of our attendees tonight had attended my talk about the advanced views. So yes, it is rotate the probe 30 to 60 degrees counterclockwise. And I have done that in the videos on the heart model. So I believe this was done as much as I can explain it with the 3D model. So this question number 3 on calculation of stroke volume, and I had mentioned that as well in my talk. Which method is the correct for calculating stroke volume using measurements from 2 different views? So which 2 views you can think of, and the answers are here. Is it the LVOT diameter in apical 5 and VTI in parasternal long, LVOT diameter in parasternal long and VTI in apical 5, LV end diastolic volume in apical 4 and heart rate in parasternal short, aortic valve area in parasternal short, and peak velocity in apical 3, LVOT diameter and VTI exclusively in subcostal view. Again, another easy question just to highlight the importance of the VTI and stroke volume relationship. Okay, 50% or 30 seconds, please. Please feel free to drop anything confusing or if you have anything not well understood in the chat function, and we will review that. Please, Ashraf, and I'm just following the quiz here. So if there's anything in the chat box I need to give attention to, please let me know.
Sure.
Okay. So perfect. So let's end the poll, please. Excellent. So measure the LVOT diameter in the parasternal long and get the VTI from the apical 5-chamber. Well done, 68% right. So we'll get the question a bit now more difficult. So we'll go to Ashraf's lectures on the LVRV assessment to measure the LV end diastolic area for advanced assessment. What is the correct technique? Trace the epicardial border at papillary muscle level, trace endocardial border at mitral level at the end of T wave, trace endocardial border at papillary muscles level and start from the QRS at the start of the QRS, trace the endocardial border including papillary muscles in apical 4, measure linear diameter from septum to posterior wall at end systole. Okay, it's in the poll. Let's see. Okay, so I have, sorry, okay. So 38%, 13 candidates answered the right answer, which is number C, trace the endocardial border at the level of the papillary muscles at the start of QRS complex, at the end of the T or at the start of QRS complex. So end diastole is just before the isovolumetric contraction phase at the beginning of the QRS complex. Okay, so this is the right answer. Hopefully no confusion about this one. So this question about coronary artery distribution and regional wall motion abnormality, and I promise you, you will not sit any exam in your life about echo without question about regional wall motion abnormality. It's a cornerstone. So which regional wall motion abnormality matches the suspected coronary distribution in an acute myocardial infarction? Basal anterior wall echinesis, apex and anterior wall hypokinesis, LAD occlusion, inferior wall echinesia, which is circumflex occlusion, lateral wall and LAD occlusion, mid-inferior wall equals PDA only. Okay, may we close that question, please? Show me the results. Perfect. Answer B. Sorry, I need to respond to someone knocking my door. If you, Ashraf, take over for a second. I'll put myself on the mute.
Sure. So I will leave the comment for Dr. Ali to come, but just take this pause to highlight the important announcement, which is there are two very important webinars coming. One on 21st, this will be the Advanced ED webinar, and we have emergency heart failure, a heart failure patient present to ED, very interesting cases. And we have on 20th of April, the pulmonary embolism webinar. And I will present the echo rule in pulmonary embolism. And this was part of this promised live webinar, the first webinar. We should cover the pulmonary embolism, but we will cover this during the next webinar, which is April 20. Go ahead, Dr. Walid.
Thank you very much. So as you had seen with Ashraf, he spoke about the coronary artery distributions. So the left anterior descending is covering the anterior wall, the anterior part of the septum, while the right coronary artery typically supplies inferior wall and inferior part of the septum. The CX covers the lateral wall of the left ventricle, and the basal mid-anterior walls are also shared between the LAD territory. So as you had seen here, I'm not sure if you had picked the answer. So the correct answer here is B. I didn't have a lock on what did you say in that answer. I'm sorry for that. So next question is about EPSS, E-point septal separation, which Ashraf had significantly highlighted. So please tell me which statement describes that E-point septal separation and its significance. So the point septal separation in parasternal short axis view in the M mode, more than 7 millimeter indicates normal LV function, or at the mitral tips and more than 7 millimeters suggest reduced ejection fraction. At apical 4, wave Doppler less than 5 millimeters indicates diastolic heart failure. Distance between posterior mitral valve leaflet and posterior LV wall valid only in mitral stenosis and significant aortic regurg. Okay, so give a few seconds more. Whenever you exceed 50%, you can end the poll. Habiba, please, thank you. Excellent. Okay, so B, Thank you very much. So A answered by 3%, B answered by 88%, so well done. Thank you very much. Yes, so I will refer you to Ashraf's talk. What I would like to highlight why in mitral stenosis and severe aortic regurg, you cannot use E-point septal separation to assess for LV function. Imagine this is the mitral valve. It's closing and opening during diastole and then closing during systole. So if it is more than 7 millimeters, this indicates heart failure. So the movement is restricted. And I would like you to imagine that the mitral stenosis is, you can't get the mitral valve opened properly because it's a stenosed valve. And here why E-point, which is the anterior part of the tip of the anterior mitral leaflet going toward the septum. When it's restricted, it will be restricted by the mitral stenosis. So what about the aortic insufficiency or aortic regurgitation? Yes, because when the LVOT is filled with backflow during diastole, it will close the anterior mitral leaflet. It will push back. So the regurgitant fraction or regurgitant flow during systole and during diastole will be both affecting the anterior mitral position. So it will restrict the movement. So in aortic insufficiency and mitral stenosis, E-point septal separation is not fit for purpose. Hope that clear. The next question regarding right ventricular dysfunction, and here we are going to Prof. AVP Antoine Villar-Barrault about his talk about RV dysfunction in early sepsis. Which of these statements is the most accurate? It's rare, so RV dysfunction is rare in sepsis and happens only in late septic shock. It's associated with decreased mortality. It's common and associated with worse outcome. It's primarily caused by hypovolemia alone. It has no impact on hemodynamic management, and it's an easy question if you attended Prof. AVP talk. We can end that poll. It's an easy one. As you may have expected, yes, it's very common and carries very significant outcome. Why? Because your mainstay of treatment of septic shock is, as per the very old Rivers et al. Trial, fluids, vasopressors, inotropes, if you are not using ultrasound. So the first thing you use is fluids and then intubation and mechanical ventilation. Sorry, I have to go again for a few seconds. Sorry for that.
No problem. So right ventricle in ICU is typically forgotten and typically involved in maybe every ICU patient, because there are a lot of factors in ICU that directly affect the RV. Sepsis, as the question raised here, is pointing toward this. Sepsis cardiomyopathy, some people, they believe that this involves only the left ventricle, and a matter of fact, RV is equally involved, like the left ventricle, in septic cardiomyopathy. And it can cause RV cardiogenic shock. And treating hemodynamically unstable patients with giving IV fluid without looking at the RV to see if it's dysfunctioned or not, it's a common rule that RV dysfunction cannot tolerate fluid. And you have to go with, number one, you unload the RV by managing the reason for the RV dysfunction. Number two, you avoid giving IV fluid, or if you want to give IV fluid, you have to give it to those who respond to fluid. So they have to be responsive to IV fluid. And reduction of fluid responsiveness means that you have to have evidence that the cardiac output will increase if you give IV fluid. The problem is here that predicting fluid responsiveness in RV dysfunction is also a very big problem. You might have positive pressure I mean, positive fluid responsiveness prediction, i.e., numbers might say that patient is responsive to IV fluid, but what you see is because of RV dysfunction, the heart-lung interaction. We will have a webinar on this because it's very, very important to understand this concept, RV. So sepsis induce RV dysfunction, PEEP induce RV dysfunction, recruitment maneuver induce RV dysfunction, hypercapnia induce, acidosis induce, a lot of factors that we see every day in ICU. Back to Dr. Walid.
Okay, I am back. I'm sorry for that. Can you hear me?
Yeah.
I'm not sure. Okay, so I don't know if you can hear me. I believe it should be fine. I just lost my iPhone. Okay, so if I didn't see again your answers.
So can you go to the next question, Dr. Walid?
Excellent. Okay. So thank you very much. I'm sorry for that. I'm terribly sorry for that, but it's all instructions about the on-call, and I cannot
we
really.
Understand. We understand. Thank you very much for your time.
Thank you. So we have 4 questions from the end. So ARDS and core pulmonary. Patient with severe ARDS on high PEEP develops hypotension. Echo shows RV dilation and septal shift. What's the best immediate intervention? And I put that cheat sheet from the lecture from AVB as a guide for you. If you go to this cheat sheet on my presentation and see, you will find the answer included here, and that's completely intentional. So with that patient, you will increase the PEEP to improve oxygenation.
Time because Dr. Antoine has just joined us now. Welcome.
Okay, perfect.
Nice to see you.
Welcome, Prof.
I'm
Welcome
sorry
aboard.
for the delay.
No problem. No problem.
Okay, so yes, so increase the PEEP to improve oxygenation, give more fluid boluses, start more epinephrine and reduce airway pressures, increase tidal volume, or start beta blockers. We can end the poll. So I feel we have given enough time to cheat from the cheat sheet. Excellent. So yes, it's reduce the airway pressures if this is the only answers, and norepinephrine improves that. And we'll go straight to the next question. Acute RV failure management is for patient with acute core pulmonale and shock. And we are expecting some, when we say shock state here with acute core pulmonale, that there is some interventricular dependence. What is the most appropriate initial hemodynamic intervention? Fluid boluses aggressively, start norepinephrine infusion, high dose diuretics, initiate pulmonary vasodilators routinely, or immediately put the patient on ECMO. And again, it's part of Prof. AVB talk. So please, it's a quick question again. Please, 50% and terminate the poll.
Prof. Antoine, you can comment if you wish. This is the
yes, please.
Part of the webinar, which is the poll. We decided to start the poll. Tell you.
Yeah, sure. Maybe for the previous question, of course, I agreed with the answer, but I just wanted to maybe discuss a little bit about increasing PEEP to improve oxygenation, because in some patients it could be efficient to do that. Indeed, if when you increase the PEEP, you induce more recruitment that over distension of the lung, especially, for instance, in obese patients where you apply a too low PEEP, could be also a good idea to test increasing the PEEP. And in this situation, you could induce improvement in right ventricular function. But globally, I was okay with the main answer that was proposed.
Thank you.
Perfect. So the mind map, Prof. Antoine, was to give three questions, simple, depending on the take-home message from each week. So 3 questions for every week. So I had reviewed all the lectures and put 3 questions on every week. So thank you very much. So here, clinical suspicion of endocarditis is high, but both transthoracic and transesophageal echoes are negative. So what's your next step? And if you put the pull up, Habiba, if you just start the next question. So you need to exclude infective endocarditis and stop further investigation. So because you have negative transthoracic and transesophageal echo, start empirical antibiotics without any further imaging required. Repeat transthoracic and transesophageal echo in 5 to 7 days, given that high suspicion. Proceed directly to cardiac surgery or perform CT coronary angio. And again, this is one of the main take-home messages from Professor Salama in his talk about transesophageal echo and infective endocarditis. So please put your answers. Quick question. We may terminate the poll and show the results. So 59% answered correctly. So because of high clinical suspicion, you need to repeat the transthoracic echo. And if it's still negative, repeat the transesophageal echo in 5 to 7 days. Thank you very much. So infective endocarditis and its origin, according to the contemporary global registries, particularly the ICE, which organisms is the most common cause of infective endocarditis currently? Strep viridans, Staph aureus, Enterococcus faecalis, Staph epidermidis, and Streptococcus bovis. So as per what you had attended and had seen with Prof. Michel Salama in his talk, what do you think of that? Okay, so we have 30% and 50% between the strep viridans and staph, and this is what I had expected. So as per history, or historically, the strep viridans was taking the upper hand, but as per the endocarditis prospective cohort study released recently, it is now going more towards the staph aureus. So perfect for the 48, hard luck for the 38. Who voted for that. And my last question about mitral vegetations management. A stable patient with infective endocarditis and had a mobile 1.6 centimeters vegetation and no other indications for any problems. The most appropriate management is continue medical treatment alone. Immediate surgery is mandatory. Surgery may be considered for embolic risk. Start anticoagulation, repeat echocardiography in 4 weeks. Bit tricky question, but again, I would refer you back to Prof. Michel Salama about this point in particular. So please, if you haven't picked that, depending on what you had learned from this talk, please go back and review that talk. Okay, we can release the results, please, Habiba. So excellent. So 44% of our attendees voted for surgery may be considered due to the embolic risk. Yes, you need to weigh the risks and benefit here. And if the vegetation size is more than 1 centimeter, and surgery may be considered for the risk of embolization. So if it's an isolated vegetation, more than 10 millimeters, or with another indication, or more than 15 millimeter and isolated, it's a strong indication for surgery. And here it's 16 millimeters. So it's definitely a surgery indication to be discussed with the surgeon and weigh risks and benefit according to all other comorbidities. And by this one, I would like to thank you all for your interaction with the polls. And I'm more than happy to answer any questions related to that poll or related to my talk about advanced echo views. Thank you very much. The mic is back to you, and welcome aboard, Prof. Antoine Villar-Parot.
Thank you very much.
Thank you very much. You want to comment, Prof?
No specific comment except the one I already did.
Okay.
So just guide me now. What do you expect exactly?
Yeah, good. We have a question here from one of the fellow, Dr. Shadi, who's asking if the sepsis induce RV dysfunction or cardiomyopathy can come in isolation from the LV dysfunction. So you can see RV dysfunction without LV dysfunction in sepsis.
So yeah, so it's a good question. If you look at the different studies, actually everything is possible. So it means that you may have isolated RV injury with a normal LV systolic function. But usually this is especially observed in patients mechanically ventilated. If you look at patients spontaneously breathing, you have usually the association of LV and RV systolic impairment. I mean, the effect of positive pressure ventilation is really key when you have sepsis, that they explain that the RV could be in isolation impaired with a still preserved LV function.
Which drug you prefer, Prof. Antoine, to treat hemodynamic instability as a vasopressor, norepinephrine or vasopressin? This is another question.
Once again, it depends. So the first point definitively is that you need to restore the blood pressure for the RV function. If you want to support RV function, you need to restore the blood pressure. So after you have indeed two choice, norepi or vasopressin. So it depends probably first on your ability, the access to vasopressin, which is not obvious in every countries.
Mhm.
And second, maybe it could be related to the context in which you observe the RV failure. And on the dose you need to apply if you start by norepinephrine. I explain shortly. Uh, the main goal is to correct the blood pressure without increasing the pulmonary hypertension or the pulmonary artery pressure. We know that if you restore the blood pressure with only small dose of norepinephrine, you do not induce any significant increase in pulmonary artery pressure. So that's the good choice. But if you need to infuse a much higher dose of norepinephrine, at that time you could have some significant elevation in pulmonary artery pressure. So it could be a good idea here to to prefer a vasopressin, not to increase too much the dose of norepinephrine. But once again, you need to have this drug in your hands, and it could depend on the country you are working.
Thank you very much, Prof. Just before we go to the next question, this is a reminder of very important practical bedside point when you attempt to examine the RV. This is apical for views that you see here, the left ventricle, left atrium, RV and RA. The more you need to focus on the RV, the more you have to shift your probe toward the sternum more. So you expose more the RV, and this is what we call it the RV focused view. But a common mistake that we see with some of our colleagues that they overestimate the size of RV when they foreshorten the left ventricle lateral wall. So though it's very important to have the focused view, but take care before you comment on the size of the RV in comparison or in relation to the left ventricle size. You have to be appropriately having the image acquisition rightly. So do not overestimate. Go ahead, Prof.
That's a very good comment, which explains why transthoracic echo is less reproducible, because you have this typical pitfall. You may overestimate the size of the RV from one operator to the other, which is absolutely not the case if you use TEE, because with this approach, you have always the adequate and the optimal view. And so if you visualize any change in RV size, this is not related to your view. This is really related to the RV function change. So good. It's a yes, indeed, a very good comment and the usual pitfall.
Thank you, Prof.
And for that, you really need to have the interventricular septum vertical at the center of the screen of the echo, which is exactly the left image you show us.
Okay, good. Prof, when you have this agreement between the different assessment tools or modalities like TAPSI, S-Wave in tissue Doppler, the FAC, or your visual assessment, which one you advise your juniors or your fellows to go with and you trust more?
If you follow the physiology, the Harvey physiology, if the Harvey is non-dilated, there is no issue, no significant issue about the Harvey function in the ICU. So the main advice that I said to my fellows regards the evaluation of RV size. If there is an obvious RV dilatation, this is something that you may visualize just by eyeballing. And if there is not, probably there is no big issue regarding RV function.
And which degree of dilation makes Prof. Antoine start to worry? Mild, moderate, severe?
So that's a tricky question, you know. I will say in all cases, when the RV is bigger than the LV, there is a big problem in all cases. So the point is more when the RV is dilated, but not bigger than the LV. And if you look at the different studies, probably that's difficult by eyeballing to say this is significant or this is not significant. And so in this case, you need to trace the RV and LV and diastolic area and to do the ratio between both. And in the studies I was speaking about, usually this is above 0.8. When this ratio is above 0.8, that you have significant problem related to RV function, including the absence of real responsiveness, for instance, because there are so many papers showing that when this ratio is above 0.8, your patient is read unresponsive.
Okay. Walid, feel free if you want to comment or ask any question, or you find any question in the Q&A while I'm...
Thank you very much, Ashraf.
Go ahead.
There is a question by Tariq Wahba I would like to comment on. So he said, a 36-year-old chronic heavy smoker admitted with acute onset of hypoxia and short of breath, which is a very common scenario. Echo showed RV dilatation and pulmonary artery pressure is 47 with a dilated RV, but CT PE is negative. And he's asking, would you consider therapeutic anticoagulation even no positive PE there? And I would like to refer to the name of the RV syndromes. RV syndromes means it's an acute RV dilation, and it's caused by a lot of things, including pulmonary embolism, air embolism, fat embolism, amniotic fluid embolism, even hypoxia, hypercapnia. Anything that causes acute severe hypoxemia increases the pulmonary vascular resistance dramatically and causes that. That's why the gold standard to anticoagulate or to thrombolize is always to find a clot. So the most specific here is the CTPA. I wouldn't do anything if CTPA or CTPE is a negative. So I wouldn't do that, because even the hypoxia, chronic or acute on chronic with a pneumonia, may be the cause of this RV dilation. And you wouldn't expect a patient who is hypoxic because of pneumonia or high PEEP or hypoxia or hypercapnia or severe pain, anything that causes massive sympathetic stimulation, to respond to your anticoagulation. You are here shooting the wrong target. And I would really, after my answer, like to hear from Prof. AVB if you want to comment on that.
No, I fully agree, Walid, with your comment, definitively. And I would add that even I will add another usual scenario, which is cardiac arrest. You may have a patient coming in the ICU for cardiac arrest after resuscitation with potentially a clinical history that could be that could suggest pulmonary embolism. And you do the echo, and this is not unusual to have, after the resuscitation, a significant RV dilatation. And even in this situation, I don't do any fibrinolysis because I want to visualize the clot. And especially, I know that maybe a few minutes later, after the resuscitation, the right ventricle could be now normal. So I need either to do the TEE to look for any clot in the pulmonary arteries, because I can visualize the right and the main pulmonary artery using TEE, or if I can and the patient is stabilized, I will do the CT scan. And always I need indeed to visualize the clot before giving thrombolysis. Even after cardiac arrest, I think this is really a key point.
Yeah.
Thank you very much. Yes, I totally agree.
Takes us to another dilemma here. We face commonly in ICU ERDS patients who might develop, on top of their very critical, they develop more hemodynamic instability or something. And they are potential to have all of the differential diagnosis of RV dysfunction actually. So ARDS itself, the mechanical ventilation interventions itself, sepsis-induced RV dysfunction, or pulmonary embolism even. Are there any in the echo finding that can help to differentiate the underlying possible causes of acute RV dysfunction in this critically ill patients?
So I will say maybe two things. The first is that you may have an idea, you may evaluate the risk for the risk score, sorry, for developing cor pulmonale. And this is something that we indeed previously published. I mean, if the hypoxemia is not so severe, if there is no hypercapnia, if the driving pressure is not really elevated, and you have acute cor pulmonale, there is some discordance, and you may maybe to think about something else. So this is the first point. And the second one, if you look at the studies, it's not so frequent during the ICU to have, let's say, massive pulmonary embolism in patient already hospitalized in the ICU. And if you have a suspicion, I would recommend to perform first the TEE, once again to control the pulmonary arteries, and second, of course, to do deep vein ultrasonography, just to look at if there is any suspicion of clot into the deep vein thrombosis. So I will use these two approaches to rule out maybe PE, which is really unusual in my experience in patients with a severe RDS with acute cor pulmonale. Maybe the only situation few years ago where it was less obvious was in patients with COVID-19, because as you know, frequently this patient could have the association of RDS and thrombosis into the pulmonary arteries.
Of course, you're going to be very lucky if you see the thrombus itself in the pulmonary artery or in the clot in transit. This will make the life easier. We are very happy that Michel Slama also joined us now. Thank you, Dr. Prof. Michel, for joining tonight. So if Antoine, Michel, and Walid asked this question, I have the echo, and I have semi-invasive or invasive hemodynamics tools. Which one I trust more? Can we start with Prof. Michel Slama?
Yes. Again, Ashraf, your question about what do I have to choose between what and what?
Between the echo and bedside in the ICU environment and the thermodilution technologies, including the Swangans. Which one you trust more?
So for pulmonary embolism?
For whatever is.
For everything.
For hemodynamic instability, let's say.
So for my point of view, I think it's like a complementary methods. First, we have to keep in mind that echo is not continuous tool for assessment of hemodynamics. Is semi-continuous, so you have to do it again if any problem occurs. But the problem that the Swan Gans doesn't give you the real pathophysiology of what happens when you have an hemodynamic impairment. So I think that from my point of view, I would always try to start with transthoracic and T examination, particularly in patient under mechanical ventilation, intubated, because I will have the real pathophysiology of the hemodynamic impairment. I will check for the right ventricle, the left ventricle. I will have an assessment of the right pressures. I will have an idea of the filling left ventricular filling pressures, and I will see the heart, which is the only tool that we can use at the bedside, that it show you the heart and it show you exactly what happens in terms of pathophysiology. In contrast, you have the Swan-Ganz catheter, for example, the thermodilution, and so it could be useful for my point of view in two clinical situations. First, if you don't have a good assessment of the PAOP, of the wedge pressure, for example, when you try to wean the patient from the mechanical ventilation, and then you fail that, and you don't know if it is due to a cardiac problem or due to a respiratory problem. And sometimes it's very hard to assess filling pressure by using a transthoracic or T examination. So at that time, I used to insert the Swan-Ganz catheter and check the PAOP during the SBT, so during the spontaneous breathing trial. And then at that time, it could be very useful to have the Swan-Ganz catheter. And at that time, it comes like a complementary technique that in addition to the echocardiography. The second situation is when you really need to follow with really attention the patient. For example, if you want to follow the cardiac output, of course, maybe you need some
continuous
continuous cardiac output assessment. So for my point of view, I see only in these two situations, but always, and the message is very important from my point of view. Always, if you have any impairment of the hemodynamics, always you have to control using echo. You have to check always and to repeat the examination as many times as it is needed. And you have to control the effect of the fluid to the patient. You have to control the effect of dobutamine or introducing the vasopressin or introducing beta blockers if you want to use beta blockers. Always you have to do it again and to have like a follow-up by using echocardiography. And it's for my point of view, a very important message. It's not only one shot, but it's really a technique that you have to use if any problem occurs or if you give any treatment to the patient to control the effect of the treatment to the patient.
Very clear. Thank you, Prof. Prof. Antoine,
can I ask your permission, Prof. Antoine, to go next? Because I will go to the ICU handover in 2 minutes, if you allow me.
Go ahead.
Is that okay? Good. Thank you very much. I would like to welcome Prof. Salama first. Very nice to see you after a long time, Prof. Salama. So if you ask me, Ashraf, my opinion, it's never PICO or echo or invasive or non-invasive. Every tool has very good strength. Echo, you can do that in ED, from the arrival of the patient to ED, and you can decide fluid or no fluids, inotropes or vasopressor, whatever. So this is not a possibility to be for a Swan-Ganz or invasive cardiac output monitoring. PICO is a very nice tool. For instance, you can do central line and arterial line, and then do the thermodilution, not even with the Swan gans, and you measure that even by nurses who are trained to do that overnight every 1 hour. When the ICU doctor is not available at bedside to repeat that echo every 1 hour. So every modality, PICO and echo, has very strong points to support its use. And if you add both together, that is the best, and I would say the most optimum care that everyone deserves. Because if you are using vasopressor, you use the central line. And if you use a central line and arterial line, you can do the thermodilution by PICO. Then you combine both. You don't have to repeat the echocardiography for every single modality change or treatment change. You can add inotropes and vasopressors, and you will see the vegetation and how the heart is pumping and all that stuff. So you need to see the heart, and in the same time, you need to repeat the exams. And I believe if you combine echo and PICO, you have done the best. Thanks so much, and I will have to leave now, Ashraf. It's the ICU handover time. Thank you.
Thank you very much, Walid, for coming. Thank you for your time.
Thanks so much.
Thank you very much. Prof. Antoine, go ahead.
No. Just my last answer, because as I told you, Ashraf, I have to leave at 9 p.m. Paris time. Just to say that I think it's not possible now to do intensive care medicine without doing echo. And in my practice, I did not use anymore the thermodilution technique, but I do not recommend, everyone to have the same approach. I just will say that probably the big point is that you have to use the technique that you manage very well, but always in association with echo, because you cannot do any intensive care medicine in 2026 without echo at the bedside.
Just quickly, Prof. Antoine, before you leave, in 30 seconds, I'm sure you came across the latest guidelines of pulmonary embolism management, the AHA and the other societies' guidelines. How do you see the value of echo in these guidelines? Are they underestimating the role of echo?
No, I am not sure they are. I think they have the good approach because echo is very rarely a diagnostic tool. Indeed, if you see a clot into the right heart, you have your diagnosis. And this is mostly to rule out, I would say, a pulmonary embolism. And this is exactly as the echo is proposed. I mean, you have in front of you a patient with circulatory shock. You do the echo, the RV is normal. You can rule out pulmonary embolism with a very good safety and accuracy. Sorry. So no, I think that they do not underestimate the room and the role of echo. Probably in this specific situation, the echo is well balanced in the guidelines.
Good. Thank you very much, Prof. Thank you for joining.
Sorry once again, and bye everyone. It was a pleasure to be with you few minutes. Ciao.
It's all good. Thank you very much, Prof. See you later.
Yeah.
Prof. Salama, this is, we need your comment on this case for the fellows, and then I will direct the questions to you. This is a 65-year-old female who is known to have end-stage renal failure on regular hemodialysis, and she was intubated for volume overload and was found to have difficult to wean. Every time on pressure support prior to TB's trial, she goes into pulmonary edema. There was no sepsis evidence, cultures were kept negative, and this is the bedside echo done for her. Can you please comment on?
Of course, I will try. Let me check. Sorry for that.
This is apical 4, apical 2, and little modified apical 2.
Okay, so I cannot see very well, but from my point of view here, from here, I don't know, but it's very hard to say. So I see that there is a large left ventricle, because if I check with the scale, with the size, it would be something like 55 or 60 millimeters. I don't know. I can see that the systolic function is really impaired from apical 4-chamber, 3-chamber, or 2-chamber view.
Yeah, you see the mitral valve and the mass is attached to
Yeah, and from, yes, very hard, but I see that there is something which looks like attached, but I don't, let me check to the, maybe to the anterior leaflet from here. Sorry, I am on my phone, so it's image is very small. So, but I can see that there is a big mass which is moving inside the left atrium and into the left ventricle, attached to with different lobes, and it's like lobular and attached to the anterior leaflet. And so I think that it should be like maybe a vegetation. So we have to check for a color Doppler to see if there is any severe matter regurgitation due to this possible vegetation attached to the mitral valve. And as well, the left atrium is enlarged.
Yeah, this is the color Doppler here, and it shows.
So in the color Doppler, it looks like having a mitral regurgitation, but central mitral regurgitation, more maybe due to dilation of the mitral annulus from here. I don't know if you confirm that, because you know, the image are, you know, moving, the sweep speed is very low, and
okay.
and so it's very difficult for me to have a good idea of this mitral regurgitation.
Let me go to this one and ask you, how can we differentiate between the calcifications, heavy calcifications, vegetations, and thrombus attached to the mitral valve? Is there a
Okay.
way that you can recommend?
Okay, that's a very, very important point. So usually it's very rare to have a thrombus attached to any valve. So usually when you have a thrombus, it's attached, it is at the apex of the left ventricle, or into the left atrium. Sometimes you may have like a mass inside the left atrium attached to the interatrial septum, and most of the time it's a myxoma. But here it's not a myxoma, obviously. It's a big heterogeneous mass attached to the mitral valve, and it's moving inside the left ventricle, and after that inside the left atrium. So it's not a myxoma. It couldn't be a thrombus. So the discussion is the calcification now. Usually the calcification is it starts at the mitral annulus, and usually it's very rare to have a calcification only on the mitral valve. It is possible. Sometimes you may have some calcification, but usually you have a big calcification as well on the mitral annulus. And here, from my side, I don't see really a big calcification on the mitral annulus. So at the end, this mass looks really like a vegetation for my point of view. Again, I don't have a really good image, so maybe you can maybe discuss this point, Ashraf.
Okay. If you look at, if you have your computer, and I hope the fellows they can see with me that the mass is attached to both leaflets, the anterior, anteromedial, and posterolateral leaflets. And actually, if you guys look carefully, you're gonna see that this mitral valve leaflet is as if it's a cut. So, and if you look at the mitral regurg also, I'm sure the prof cannot see it through the mobile, but there is some eccentric jet here, which could be because of the annulus rupture or some of the papillary muscle rupture as well. So the question was, is this calcification? Usually calcification doesn't cause this significant damage to the leaflets, is it?
Yes, I agree with you, Ashraf. Yeah.
Yeah. And the message here is that when you have somebody who is difficult to wean from mechanical ventilator, then you have to ask yourself three questions for difficult to wean. Question number one related to the heart, and heart should be LV and RV, right side and left side as well. Low cardiac output, heart failures, regurgitation, aortic and mitral. And then the lung is the second question. And third question should be the diaphragm. And the failure to wean is because of one, if not more than one, of these three common causes of failure to wean. And we're going to have all of this discussed in separate weeks during our course. We already passed 1 hour now, and we almost done for this live webinar. It was very great to have Professor Antoine and Professor Michel Slama and our colleague Dr. Walid Al-Habashi. And it was very nice to host all of you fellows tonight. Again, we are encouraging you to bring your cases for discussion and to share any questions in the WhatsApp group or through the email. And we can, as I told you before several times, we can meet together or with any faculties. They are all very supportive, and we can call them for a meeting. Thank you very much again.
Thank you, Ashraf, for your invitation for this webinar. And congratulations, because it was very interesting.
Thank you very much, Prof. Thank you very much for joining. Also, thank you, ICOM company, and Habiba, Nurhan, and Ala for this great support we have today. Thank you very much, and see you in next webinar. 20 will be for pulmonary embolism, 20 April, and 21 will be heart failure in ED, in emergency department, as one of the live webinars for the advanced emergency module. Thank you very much. See you all.